Welcome to the PMHNP Podcast, the definitive podcast for those passionate about mental health throughout every stage of life. Whether you're an aspiring professional, a seasoned expert, or someone simply keen to understand the intricate world of psychiatric care, you're in the right place. I'm Dr. John Rossi, a certified PMHNP, nurse educator, and lead content creator and instructor at Clarity Education Systems and www.pmhnptesting.com. Hello and welcome back, everybody. I am excited to be here with you again. This is our newest PMHNP podcast, and we are going to be going over a comprehensive guide to treating opioid use disorder, also known as OUD. So opioid use disorder is a chronic and complex condition that affects millions of individuals worldwide, leading to significant health, social, and economic challenges. So effective treatments of OUD often require this multifaceted approach, combining behavioral therapies, support systems, and probably most crucially, medication-assisted treatment, or what we have already learned about in previous podcasts as the MAT, or the MAT. So MAT has been shown to enhance recovery outcomes, reduce opioid-related mortality, and really improve the overall quality of life for the individual, for the patient, for anyone that's struggling with OUD. So this podcast session aims to provide that comprehensive overview of the medications prescribed in the treatment of OUD, focusing on their mechanisms of action, clinical applications, their benefits, their potential side effects as well. So by understanding these medications, you, as the PMHNP, can better support patients on their journey to recovery, right? Tailoring treatments to that individual, their individual needs, and their circumstances. Now, this is going to be a pretty thorough overview of OUD treatment, so I wanted to give us some clear objectives as we move through this. I've also supplied an actual document, Word document, that will guide you through this entire podcast. It's almost like a course in and of itself. So if you want to be able to see this in print, please go to the student portal. It will be available with this podcast on the PMHNP student portal. So first, we're going to take an in-depth look and gain in-depth knowledge of the three primary medications used in MAT. That's going to be Methadone, Buprenorphine, and Naltrexone. Understanding how each medication works, its appropriate use cases, and its role in OUD treatment. Second, we're going to learn about the clinical protocols for initiating and maintaining medication therapy. This is going to include considerations for dosing, monitoring, and managing side effects. Third, we need to understand the importance of combining medication with counseling and behavioral therapies to provide that holistic treatment plan that addresses both the physical and the psychological aspects of OUD. Fourth, we want to emphasize the importance of personalized treatment plans that consider patient preferences, co-occurring disorders, and unique life circumstances that enhance adherence and recovery outcomes. Lastly, we're going to discuss the common misconceptions and stigma that surround MAT and explore strategies to overcome the barriers and assess and acceptance, ensuring that more individuals can benefit from these life-saving treatments. So OUD is recognized as a chronic relapsing brain disease characterized by an overpowering need to use opioids despite harmful consequences. Central to this disorder is a deficiency in dopamine. This is a key neurotransmitter in the brain's reward system. Dopamine is a signaling agent in the brain that plays a crucial role in memory formation and motivational processes. So it really helps us remember both positive and negative experiences, which in turn is going to motivate us to repeat pleasurable activities. Now, in the context of OUD, the brain's dopamine system is hijacked. This leads to an intense craving and a compulsive drug-seeking behavior. So the dopamine pathway, often referred to as the reward pathway, includes several key brain regions. First is going to be the ventral tegmental area, or what's known as the VTA. So the VTA is a starting point of the dopamine pathway, where dopamine-producing neurons originate. Next, we have the nucleus accumbens, or the NA. This region receives dopamine signals from the VTA and is critically involved in the reinforcement of the reward process. Third is the prefrontal cortex. Now, this area is responsible for higher order functions such as decision-making, impulse control, and moderation of social behavior. It processes the dopamine signals and helps regulate our response to rewarding stimuli. The disruption of dopamine in this pathway in individuals with OUD is going to greatly affect their ability to experience pleasure from everyday activities, driving them to really seek out opioids to achieve those desired effects. So this results in a cycle of use, resulting in cravings and then relapse that is difficult to break without intervention. So the powerful memory imprints created by dopamine release during opioid use further reinforces the behavior, making recovery a challenging journey. Understanding the neurobiological underpinnings of OUD is crucial for developing effective treatment strategies. By targeting the dopamine pathway and addressing the associated deficits, we can better support individuals in overcoming this debilitating disorder that causes so much disruption in a person's life, not only in their life, but in their family's life as well. So let's go even a little deeper in understanding the dopamine abuse connection. So the dopamine system is activated when we engage in activities that are naturally rewarding, leading to the release of dopamine and that subsequent feeling of pleasure and satisfaction. So its secretion in the primitive brain is a key trigger for our primary reward system that reinforces those behaviors that really helps to ensure survival and well-being. So situations that are going to trigger dopamine release. One would be eating a good meal. So when we consume food, especially something delicious, our brain releases dopamine. This response encourages us to seek out and then consume other food regularly, ensuring our survival. Second would be falling in love. So the experience of falling in love or forming strong social bonds also triggers dopamine release. This reward helps to establish and maintain close relationships, which obviously is essential for emotional support and cooperation in social groups. Third is having sex. So sexual activity results in a significant release of dopamine. This reinforces reproductive behavior, ensuring the continuation of the species. Fourth, we look at consuming certain drugs. So many substances of abuse, such as opioids, cocaine, and alcohol, cause an unnatural surge in dopamine levels. This intense release creates a powerful feeling of euphoria, which the brain interprets as a highly rewarding experience. The artificial stimulation of the reward system by drugs can lead to this repeated use as individuals seek to recreate those pleasurable feelings. So let's take a look at the dopamine abuse connection. The primary reward system, which evolved to reinforce behaviors that are beneficial for survival, can be hijacked by substances of abuse. When drugs artificially elevate dopamine levels, they create a powerful incentive for continued use. And this leads to the following cycles. First is going to be initial use. The first use of the drug may be driven by curiosity of the desire to experience pleasure. The resulting dopamine surge creates a strong feeling of euphoria. 2. Reinforcement. The brain remembers the intense pleasure and reinforces the behavior, making the individual more likely to seek out drugs again. 3 is dependence and tolerance. With repeated use, the brain's reward system becomes desensitized to natural rewards, and higher doses of the drug are needed to achieve the same effect. This leads to dependence and tolerance. Number 4 is craving and compulsion. The individual experiences cravings and compulsions, drug-seeking behavior, driven by the brain's alerted reward system. And finally, there's the negative consequences. So despite negative consequences, such as health problems or social issues, this individual continues to use the drug, illustrating the chronic and relapsing nature of substance use disorders. So we do need to take a look and really understand the DSM-5 criteria for opioid use disorder, or OUD. So it is defined by the DSM-5 as a problematic pattern of opioid use leading to clinically significant impairment or distress. And this is marked by and manifested by at least 2 of the criteria that have to occur within a specific 12-month period. So let's take a look at them really close here. So number 1 is going to be opioids are often taken in larger amounts over a longer period than was intended. So that's like if a prescription is given for a certain medication, after that prescription is over, the patient continues to take it. Number 2, there is a persistent desire or there's this unsuccessful effort to cut down or to control the opioid use. Number 3, a great deal of time is spent in activities necessary to obtain the opioid. So, going out into town to try to find somebody who can deal for them, constantly going to a family member that maybe has a prescription for a certain drug, or, anything that's going to take up a great amount of time. Number 4, craving or a strong desire or urge to use opioids. Number 4, recurrent opioid use resulting in failure to fulfill that major role obligation, such as work or at school or at home. Number 6 is continued opioid use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of opioids. Number 7, important social, occupational, or recreational activities are given up or reduced because of opioid use. Number 8, recurrent opioid use in situations in which it is physically hazardous. Number 9, continued opioid use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by opioids. Number 10 is tolerance, as defined by a need for markedly increased amounts of opioids to achieve intoxication or a desired effect, a markedly diminished effect with continued use of the same amount of an opioid. Now, there's a note in the DSM-5 that this criterion is not considered to be met for those taking opioids solely under appropriate medical supervision, right? Which makes sense. Number 11 is withdrawal. This is manifested by the characteristic opioid withdrawal syndrome, or opioids or closely related substances are taken to relieve or avoid withdrawal symptoms. There's also another note here. This criterion is not considered to be met for those taking opioids solely under appropriate medical supervision. So you've got all of those criteria. Of those, remember, you have to have at least 2 within a 12-month period of time. The DSM-5 also categorizes the specific severity of OUD. So we have mild, so this is the presence of 2 or 3 symptoms, moderate, the presence of 4 to 5 symptoms, and severe OUD with the presence of 6 or more symptoms. So now that we've taken a good look at what it is, kind of how it affects the body, the reward system, and the criterion for the DSM-5 OUD, let's take a look at a specific example scenario. Okay, so this person is Jane, a 35-year-old woman. She's been prescribed opioids for chronic back pain management following a car accident. Very, very, typical case. Over the past year, she's experienced some related issues to her opioid use. So, 1, opioids are often taken in large amounts over a longer period of time. So, she occasionally takes an extra dose of her medication when her pain feels particularly severe and it's exceeding her prescribed amount. All right, then 2, Jane tried to reduce her opioid use several times, but each attempt has been unsuccessful due to the return of her pain. And 3, Jane sometimes finds herself thinking about the next dose of the medication and feels the strong urge to take it even when the pain is not as intense as it used to be. So we've got 3 specific criteria that have been met. So Jane meets 3 of these OUD specifications, and this is going to qualify her as a mild OUD user according to the DSM-5. So despite having only mild symptoms, Jane is now diagnosed, which can lead to a stigma or misconceptions. She might be labeled as a drug abuser, which can affect her relationships, her employment opportunities, and definitely her self-esteem. So Jane's employer becomes aware of her diagnosis and, despite her excellent performance record, starts to monitor her more closely and limits her responsibilities. This is usually out of fear she might not be reliable or she might cause a complication in the workforce. Friends and family may start viewing Jane with suspicion, questioning whether she can be trusted with responsibilities or if she can, engage in drug-seeking behaviors when she's supposed to be doing other things. And then finally, we have the medical, stigma. This is, or the healthcare stigma. So medical professionals might begin treating Jane differently, focusing more on her OUD diagnosis than her chronic pain needs. And this is going to potentially lead to an undertreatment of her pain. So how do we mitigate this? What are some ways that we can help in a stigma situation associated with mild, in this case, diagnosis for OUD? So education is going to be huge. Educate healthcare providers, employers, and the community about the complexities of OUD and the differences between dependency and addiction. Encourage a supportive environment that focuses on recovery and management rather than labeling and stigmatizing. And then finally here, we want to provide holistic care that addresses both the underlying condition, so the chronic pain, and the mild OUD. This is going to ensure that Jane's overall well-being is prioritized, and that is really the key of holistic caregiving that we as nurse practitioners and PMHNPs provide. All right, so understanding the role of dopamine in addiction, again, this is going to highlight that need for comprehensive treatment approaches that addresses both neurobiological and behavioral aspects of substance use disorders. So let's talk a little bit deeper. We've seen a good example of what mild OUD would be. We understand the dopamine behind it. Now let's talk about those effective treatments a little closer, specifically starting with medication-assisted treatments, then moving on to behavioral therapies, and then finally support systems. All right, so substance use disorders are often treated differently compared to other chronic health conditions. This leads to significant disparities in care outcomes, which we just talked about during that case study. So these disparities reflect this kind of broader issue within the healthcare system and societal attitudes towards addiction. So I wanted to take a quick look at some of the key disparities of treatment for SUDs. One is going to be that expectation of improvement before acceptance into treatment. We see this a lot for these patients. So unlike other chronic conditions where immediate treatment is prioritized, patients with SUDs are sometimes required to demonstrate improvement or even abstinence before being admitted into a treatment program. Then there's noncompliance, right? So they often experience relapses and noncompliance with medication management or treatment, which is common in this kind of chronic treatment of these conditions. And they're often grounds for dismissals from SUD treatment programs. Rather than, being viewed as part of the recovery process, it's just an opportunity for them to get kicked out or dismissed from their programs. So in some cases, known life-saving treatments are withheld or even rationed for individuals with SUDs, despite the availability of effective medications that can significantly improve their outcomes. SUDs are frequently criminalized, with individuals facing legal consequences rather than receiving appropriate medical treatment. This approach can exacerbate the condition and hinder recovery efforts. Now, patients with SUDs are sometimes expected to discontinue medications that have been proven effective in managing their condition, such as medication-assisted treatments, or MATs, like methadone, in order to continue with their long-term treatment plans. So insurance coverage for SUD treatment is often limited or non-existent. This is going to make it difficult for patients to access the comprehensive care they need. This includes both pharmacological and also behavioral therapies. So what does all of this mean as it pertains to SUD patients? So withholding and rationing life-saving treatments can lead to higher mortality rates among individuals with SUD, and treating SUDs as a moral failing or criminal issue rather than a medical condition perpetuates stigma, right? Discouraging individuals from seeking help. So a lack of continuous and supportive care increases the likelihood of relapse and reoccurrence, making their long-term recovery more challenging. So limited insurance coverage and stringent treatment entry requirements into programs create significant barriers to accessing effective care. So to improve the treatment and outcomes for individuals with SUDs, it's crucial to address the disparities, all right? So first thing we need to do is policy reform. We, as nurse practitioners, need to advocate for policies that treat SUDs as medical conditions, ensuring access to comprehensive, evidence-based treatments without punitive measurements. Next is we have to expand insurance coverage for all aspects of SUD treatment, including MAT, counseling, and long-term supportive services, right? Then we need to develop integrated care models that address both physical and mental health needs of individuals with SUDs. And this is going to help promote that holistic and continuous care. We need to educate healthcare providers, the policymakers, and the public about the nurture and the nature of SUDs and the importance of compassionate, evidence-based approaches. We need to create supportive environments that encourage recovery, including reducing stigma and providing resources for individuals and their families as well. So let's take a look at another case study. I know that's something that everybody has been asking for more of. So we're going to take a look at John, a 28-year-old male. He's been struggling with opioid use disorder for several years, and he initially began using prescription opioids following a severe injury and subsequent surgery. So over time, his use escalated, and he transitioned into using heroin. Now, despite numerous attempts to quit on his own, John has been unable to maintain long-term sobriety. This is a very common situation that we see with SUD patients. So John seeks help from a local addiction treatment center, hoping to enroll in their inpatient program. During the intake process, he is told that he must demonstrate at least 30 days of sobriety before being accepted into the program. Frustrated and feeling hopeless, John leaves without receiving any immediate assistance. So without the support he needs, John relapses. He is arrested for possession of heroin and is sent to jail. During his time in jail, John experiences severe withdrawal symptoms, but he does not receive any medication-assisted treatment, or MAT, to alleviate the discomfort or reduce his cravings. So upon release, John seeks out more outpatient treatment, and he is prescribed buprenorphine to help manage his cravings and stabilize his condition. However, his insurance company only covers a limited number of therapy sessions and does not fully cover the cost of his medication. Financially strained, John struggles to adhere to his treatment plan. A few months into his outpatient treatment, he experiences a relapse and a lapse and uses heroin again. When he discloses this to his treatment provider, he is dismissed from the program for non-compliance, leaving him without the support he needs during a critical time. So John's repeated experiences of being denied access to treatment, facing punitive measures for relapse, and dealing with insufficient insurance coverage lead to a cycle of relapse and recovery attempts. His conditions worsen, and he becomes increasingly isolated and discouraged. So instead of being required to demonstrate 30 days of sobriety as we start to address some of the disparities in John's case, John should have been accepted into treatment immediately. Early intervention could have provided him with the support necessary to really stabilize himself and his condition and begin his recovery journey. Now, while incarcerated, John should have received MAT to manage his withdrawal symptoms and reduce cravings. This would have helped maintain his program and his progress and reduce the likelihood of relapse upon release. John's insurance should have covered full cost of his medication and therapy sessions, ensuring that financial constraints do not hinder his treatment adherence. We have to look at comprehensive coverage that would allow him to focus on his recovery without the added stress of medical expenses. Now, instead of being dismissed for a lapse, John should have received additional support and intervention to address the relapse and strengthen his recovery efforts. Recognizing that relapse is often a part of the recovery process, and a compassionate approach would be encouraged in order to continue engagement in treatment. All right, so now we have a pretty good idea of what opioid use disorder is, how it's categorized by the DSM-5, and many of the disparities that patients face when they're trying to go through the recovery process. But what do we need to know as PMHNPs? Primarily, we're going to be dealing with the medication assistance. And so let's dive a little deeper into the MAT. And remember that it's combined use of medications with behavioral therapies. So this is an integrated approach, right, to address both the physiological and psychological aspects of addiction. So MAT involves the use of specific medications to help normalize brain chemistry and stabilize dopamine levels. These are often disrupted, obviously, in that opioid use. These medications reduce cravings and withdrawal symptoms, and this is going to help allow the patient to focus on recovery. So by stabilizing dopamine levels, MAT allows the brain to, in a sense, reset. This stabilization creates a more conductive and conducive environment for behavioral therapies to be effective, and then helping the patient develop coping strategies and address the root causes of their addiction. All right, so quick overview of what these medications are. I know we talked about them a little bit earlier. And then once we've got a good idea of what they are, we're going to split off and discuss these in greater detail and how they work for this behavioral health situation that is primarily the addiction process. So first thing is methadone. This is a long-acting opioid agonist that reduces withdrawal symptoms and cravings, and this occurs by activating the same brain receptors as other opioids, but in a controlled manner. Next is buprenorphine, and this is a partial opioid agonist that helps alleviate withdrawal symptoms and cravings with a lower risk of misuse compared to full agonists. It can be prescribed by certified providers, and it can also be taken at home. And then finally, we have Naltrexone. This is an opioid antagonist that blocks the euphoric effects of opioids. And this is really going to help prevent relapse. It's available in both an oral and an extended release injectable form. All right, we can't talk about medication or MAT without also addressing the behavioral therapies. So behavioral therapies are crucial and are a major component of MAT, providing patients with the tools and support needed to change their behaviors and their thought processes and patterns related to substance use. And you need to communicate that to your patients. They need to understand that it's not just about meds, it also encompasses this behavioral therapy approach. So these therapies include cognitive behavioral therapy, or CBT, contingency management, definitely motivational interviewing. That's a huge part of it. And there's all other types of, evidence-based approaches. We also need to include some, trauma-focused therapy at times, depending on the comorbid situations that are occurring with the substance abuse. Okay, so MAT can be compared to other treatment approaches for something like diabetes. So let's kind of do a quick comparison. So medications for diabetes, right? We have insulin, metformin, for example. So just as insulin and other medications are used to control blood glucose levels in the patients with diabetes, medications in MAT, they're really designed to help manage the biochemical imbalances caused by opioid use disorder. So patients with diabetes are also encouraged to make lifestyle changes, such as improving diet and increasing physical activity, to manage those conditions effectively. And this is very similar to what we're asking OUD patients to do. They have to work on lifestyle changes. This is through behavioral therapies while they're on their medication in order to stabilize that condition. So what are the major benefits of MAT? We really want to help the patient receive an improved retention in treatment. This is so that we can help them remain in treatment and increase the chances of long-term recovery. Then we want to look at reduced risk of overdose, right? So MAT significantly reduces the risk of overdose by providing a safer alternative to that illicit opioid use. And then better quality of life. So MAT helps patients regain control of their lives, improve their physical and mental health, and then rebuild relationships. So despite its proven effectiveness, MAT faces several biases and misconceptions that can definitely hinder its acceptance and utilization. So we have to address these biases, understand them, in order to improve the treatment and the outcomes of individuals with OUD. So what are some of the misconceptions? That people believe that using medications like methadone or buprenorphine is simply replacing one addictive substance with another, and this is akin to fighting fire with fire, right? When in reality, MAT medications, they're carefully regulated and they're administered to stabilize brain chemistry and reduce harmful behaviors associated with addiction. I mean, it makes so much sense when you just stop to think about it, and that's what we need to help educate the community about. So these medications do not produce the same euphoric effects as the illicit opioids when used as prescribed. So another misconception, there is a prescription that OUD should only be treated by specialty addiction providers, not by general healthcare practitioners or PMHNPs. What's the reality to that? Treating OUD is within the scope of practice of many providers. Training and certifying practitioners and PMHNPs to prescribe and manage MAT, this is going to greatly expand the access to treatment. This goes in primary care teams as well. So another misconception, some individuals believe that true recovery means complete abstinence from all substances, including MAT medications. Now, what's the reality of this? Recovery is a personal journey, and it can include the use of medications to support stability and prevent relapse. Being on MAT does not negate a person's recovery efforts or their achievements. Another misconception, there is a belief that abstinence-only approaches are superior to MAT and that patients should aim for complete abstinence. So what's the reality in this situation? Well, it's clear. Research consistently shows that MAT is more effective in reducing opioid use and improving long-term outcomes than abstinence-only approaches. MAT helps patients stabilize and engage more effectively in behavioral therapies and in other recovery activities. All right, we've got one more here. The last misconception, some argue that since many individuals have recovered from addiction without medications, MAT is just essentially unnecessary. The reality of this is that while some individuals do recover without those meds, MAT provides a critical option for those who struggle with achieving and maintaining sobriety through abstinence alone. So different patients have different needs, right? That's patient-centered care. And MAT offers an evidence-based approach to support recovery for many different individuals. All right, so how do we address these biases then? We talked about 5 clear ones here. Well, first, we need to provide education to healthcare providers. Then we need to make sure that their patients understand, and we need to address the public at large. That's one of the things that we do as nurse practitioners. We go out and we talk to as many people as we possibly can. Get on the radio waves, get on TV, and really discuss these major topics with an audience that will reach as many people as possible. We have to teach them about the science behind MAT and its benefits. All right, so share success stories of individuals who have benefited from MAT, and then how this, counteracts the negative perceptions. All right, next we need to offer training programs for general healthcare providers to manage OUD, including prescribing MAT. So that's where you step in. It's this interdisciplinary outreach, right? So we can go out there and we can provide training to other providers so that way they can get on board with establishing MAT treatments as well. All right, then we need to offer opportunities to advocate for a broader definition of recovery that includes individuals on MAT, and use supportive and non-stigmatizing language when discussing MAT and recovery. Lastly, let's talk about evidence-based practices in this kind of combating the biases situation. We need to highlight research findings that are evidence-based and recent and current, that demonstrate the effectiveness of MAT compared to abstinence only. We have to advocate for policies. We need to get out there with our lawmakers and support the use of MAT as a standard treatment. A lot of times it's just going out there and getting to know your representatives so that that way they understand their constituents, and you figure out how to communicate it clearly to them, because they don't have a background in science. So they're just going to read what they read online and go with it. Or we can give them what they need to know at their level of understanding, so that way they have a clear path forward when they're trying to establish new rules, guidelines, and policies. All right, so medication-assisted treatment, or MAT, we've said it many times now. It should be embedded in your brain. For opioid use disorder, let's dive into each one of them. Okay, so first up, we have methadone for opioid use disorder. Methadone, again, is a full mu opioid agonist used in the treatment of OUD. Remember from the seminars that agonists bind to receptor sites and they activate. It can only be prescribed in a federally certified opioid treatment program due to its potential for misuse and the need for close monitoring. So dosing and administration. Our first initial dose is typically 20 to 40 milligrams per day. Higher doses are seen at 80 to 120 milligrams daily, and they may be more effective in moderate doses of 40 to 50 milligrams. So what are some of the adverse reactions we see with methadone? Sedation, constipation. There are some known cardiac effects, such as QT prolongation, as well as multiple medication-on-medication interactions, or those drug-to-drug interactions. So patient characteristics for methadone treatment include anyone over the age of 18 that has a duration of OUD of greater than 1 year, medically compromised individuals, presence of infectious diseases, and pregnancy are all going to kind of be things that we need to watch out for when giving these treatments. All right, so near the induction stage, we determine OUD, positive medical history of opioid use, signs and symptoms need to be there, so track marks, opioid withdrawal symptoms. We need to do an electrocardiogram, or ECG, in order to monitor QT prolongation. Naltrexone challenge to ensure opioid dependence, and clinical opioid withdrawal scale, or COWS assessment. During the initial phase, step 2, we have this the objective is to really relieve the withdrawal signs and symptoms, and we're going to provide that 20 to 40 milligram dose a day. Number 3 is early induction phase. The objective here is to reach established tolerance level. So dose adjustment of 5 to 10 milligrams increases every 3 to 24 hours as needed. And then we have late induction phase. Again, the objective here is to establish an adequate dose. So this is going to be a 5 to 10 milligram increase every 24 hours with adjustments every 5 to 10 days. Then we're going to get into the maintenance phase of methadone treatment. This is really to maintain the desired steady state effects. So dose is going to be approximately 60 to 120 milligrams a day, with 80 to 100 milligrams needed to effectively block the cravings. All right, and next up we have buprenorphine, which is a partial opioid agonist and has a high affinity for opioid receptors, meaning it binds strongly and remains attached. So despite its short half-life, the receptor affinity results in a long duration of action, and it typically occupies the receptors for 24 to 72 hours, depending on the dose. So the combination with naloxone in sublingual preparations deters intravenous abuse. All right, so reduces the risk of overdose due to the ceiling effect, where at increasing doses do not produce proportional increases in its effects. That's that partial agonist and ceiling effect. Lower risk of developing tolerance compared to full agonists, and it has generally fewer interactions with other medications. So the combination with naloxone reduces the potential for intravenous abuse, and it acts as a functional antagonist due to its high affinity, blocking other opioids from binding to receptors. All right, so what is the take-home dosing? So patients can be eligible for take-home dosing on the first day, allowing for split dosing without the need for daily clinical visits. All right, other than that, we have available in multiple dose forms, including topical patches, sublingual tablets or films, and also depot injections. Okay, so disadvantages of this medication. It must wait until the patient is in full withdrawal to avoid precipitated withdrawal. Then we have a risk of liver function impairment in some patients and common side effects of nausea. So limited flexibility in dosing adjustments with the tablet forms. And when talking about cost, it's more expensive when compared to some other treatments. There are some patient limits as well, so providers are limited to treating a maximum of 270 patients with this medication. There are also some concerns regarding lack of long-term data, so insufficient long-term data on the effects in infants and children. And then the dropout rates, clinically significant increase in dropout rates compared to methadone. So during the induction phase, the goal is to begin treatment once the patient is in moderate to severe withdrawal to prevent precipitated withdrawal. Start with a low dose and gradually increase to alleviate withdrawal symptoms and reduce cravings. And then we get to the maintenance phase, where the goal is to stabilize the patient on a maintenance dose that effectively controls withdrawal symptoms, and then we adjust the dose as needed, typically ranging from 4 to 32 milligrams daily. Okay, we do need to discuss some of the major known drug-to-drug interactions with buprenorphine and methadone. So CYP3-alpha-4 inducers. So examples would be rifampin, carbamazepine, phenytoin, phenobarbital. The effect here is the inducers of CYP3-alpha-4 can increase the metabolization and metabolism of buprenorphine, leading to decreased blood levels and reduced efficacy of the medication. Then we have CYP3-alpha-4 inhibitors. Some examples would be erythromycin or ritonavir. So this effect inhibits the CYP3-alpha-4 and decreases the metabolism of buprenorphine, potentially increasing blood levels and the risk of adverse effects such as sedation and respiratory depression. Now, benzodiazepines and other CNS depressants. So examples would be diazepam, alprazolam, clonazepam, and alcohol. The effect here, co-administration can enhance CNS depression. This is going to lead to increased risk for sedation, respiratory depression, could even result in coma and death. All right, so next up, let's talk about naltrexone for opioid use disorder. And this is an opioid antagonist with a high affinity for mu opioid receptors and lower affinity for kappa and delta opioid receptors. It effectively blocks the effects of heroin and other opioids, making it a useful medication for preventing relapse in patients with OUD. Okay, so the pharmacology of this. High affinity for mu opioid receptors, blocking the euphoric and sedative effects of opioids. It has a long half-life, allowing for flexible dosing schedules. It is given as an oral tablet, so you've got dosage options of 25 to 50 milligrams daily, usually lasting 24 to 48 hours. We have a 50 milligram once daily, a 100 milligram every 2 days, or 150 every 3 days. So first discovered in 1963, FDA approved in 1984 to treat opioid dependence. We also have intramuscular injections. So this is a once monthly 380 milligram IM injection. And it was FDA approved in 2010 for opioid dependence. So some of the common side effects are going to include gastrointestinal distress, so things like nausea and vomiting, as well as headaches, with some more serious side effects including rare liver toxicity and hepatotoxicity. So we want to monitor liver function tests or LFTs, really every 3 months or so. So some things to consider for patient candidates for naltrexone. They must be opioid-free for 7 to 10 days to avoid precipitated withdrawal. It's suitable for patients who have failed agonist treatment. It's ideal for patients with less severe forms of OUD. And it is not recommended for patients with hepatic disease due to that risk of liver toxicity. Okay, so poor adherence to oral naltrexone suggests the use of injectable formulation instead, and this is going to ensure continuous blockage. And then the once monthly injection of the 380 milligram IM, this is going to provide consistent opioid receptor blockage, therefore reducing that risk of relapse. All right, so those are the 3 primary medications associated with the MAT of opioid use disorders. But let's also talk about some adjunctive medications. So in addition to the primary medications that we talked about, adjunctive medications can be used to manage symptoms associated with opioid withdrawal and therefore support the overall treatment process. These medications can help alleviate symptoms like anxiety, agitation, nausea, and insomnia. So first up, we have clonidine. This is a alpha-2 adrenergic agonist. So clonidine works by decreasing the release of norepinephrine, or NE, which helps reduce the symptoms of opioid withdrawal. Some of the benefits: it may decrease anxiety and agitation associated with the withdrawal, and it helps reduce symptoms like sweating, hot flashes, and even runny noses. Dosage of clonidine is going to be between 0.1 and 0.2 milligrams orally, 3 times a day. Side effects can include potential for low blood pressure, for dry mouth, and sedation. So we have to have careful monitoring in order to avoid hypotension. Next up, we have promethazine. This is an antihistamine. It's available in an oral form. It's also intramuscular as well as rectal. So dosage is going to be 25 to 50 milligrams, either PO, IM, or PR as needed. So some of the benefits here: it may help with nausea and vomiting, often experienced during that opioid withdrawal, and it may really assist with sleep, helping to manage insomnia and restlessness. So some of the side effects of promethazine: possible drowsiness, dizziness, and dry mouth. We have to use with caution in patients with respiratory distress due to that potential respiratory depression. All right, so let's just do a quick summary of everything that we've talked about here today. So the role of medication-assisted treatment, or MAT, in opioid use disorder recovery. So MAT significantly increases the chance of recovery from opioid use disorder, and we have to remember that it substantially improves the likelihood of recovery for individuals with OUD by reducing cravings, managing withdrawal symptoms, and preventing relapse. Our choices of medication: the selection should be based on patient preferences, availability of opioid treatment programs, anticipated effectiveness of the medication, and the potential for adverse effects associated with each medication. All right, so offering MAT to all patients is essential. It's recommended that all patients diagnosed with OUD be offered MAT as part of their treatment plan to enhance recovery outcomes. All right, and then MAT should be continued indefinitely to maintain recovery and prevent relapse, as OUD is a chronic condition that requires long-term management when needed, as assessed and based on the PMHNP or other providers' diagnosis, treatment plan, and recommendations. So by integrating MAT into the treatment plan for OUD, you as the healthcare provider provide the patient with more effective pathways to recovery, supporting long-term sobriety, and improving overall outcomes. So hopefully this kind of gave you a thorough overview of the medications that are available for opioid use disorder, especially when we're considering COWS readings and scoring when we're looking at practice questions and exam questions for the certification exam. It's always a pleasure to be here with each of you. I thank you for your time. We are ready and willing to help you prepare for your PMHNP certification exam, or to just be available as you continue your education after certification, working in your field as a PMHNP. Again, I'm Dr. John Rossi, and I will see you in the seminars, at the next PMHNP Review Conference, or online at www.pmhnptesting.com.